Let's move to our next session, that is a young speaker session. This is to encourage our young anesthesiologists and know their perspectives about anesthesia. I'd like to call upon our chairpersons, Dr. Prashant Kumar KV. He is a senior specialist in anesthesiology at Health and Family Welfare Government of Karnataka. And I would like to call upon our next chairperson, Dr. Ashwini S. She completed her MBBS from KIMS Bangalore in 2007. MD Anesthesiology in Mysore Medical College in 2011. She worked as senior resident at St. John's Medical College in ICU Registrar at Sagar Hospital, Bangalore. Now she is serving as McGurn Teaching Hospital attached to Shivamogga Institute of Medical Science since 2013. She is presently working as Associate Professor and also teacher for paramedical students. She has 6 publications and few ongoing research studies, and her area of interest are regional anesthesia and obstetric anesthesia. Our first speaker for this session is Dr. Bhavya K, who is going to talk on standards of perioperative monitoring, what's new. I'd like to request our chairpersons to kindly introduce our speaker.
Dr. Bhavya K, Senior Resident, MMCRI, Mysore.
There's a common statement in medical school that anesthesia is 99% boredom and 1% sheer terror. But this 1% sheer terror could be a nightmare in the life of a patient and also an anesthetist. But 100% vigilant perioperative monitoring could prevent this 1% sheer terror. So let's know about the standards of perioperative monitoring in the next few minutes. Myself, Dr. Bhavya, from the Senior Resident from the Department of Anesthesiology, Mysore Medical College, Mysore. I'll be speaking under these headings. The word monitoring was derived from the Latin word monere, which means warning, remind, or admonish. First of all, why do we need monitoring? What are the goals of monitoring? It is a continual assessment of the physiological state of the patient. It is to assess the adequacy of anesthesia. It is to detect the early warnings of adverse changes. It is to intervene before any irreversible damages occur to the patient. And to detect and correct the equipment malfunction. So I'm dealing with the topic under these headings. First of all, the word monitoring was derived from the Latin word monere, which means warning, remind, and admonish. Let's know briefly about the history of this monitoring. Monitoring in the past was done through clinical methods by visual monitoring of the respiration and overall clinical appearance, and the commonly used method was the finger on pulse, that is palpation of continuous palpation of the radius pulse, and intermittent blood pressure monitoring was also done. As you can see in the picture, when Dr. W.T.G. Morton was anesthetizing the patient with ether, his assistant was constantly having his hands on pulse and he was monitoring the patient's respiration. In this occasion, we should remember an eminent neurosurgeon, Dr. Harvey Cushing. Though being a neurosurgeon, is called the father of anesthesia monitoring. He was the one who invented and popularized the anesthesia charts. He started recording BP and he insisted on precordial auscultation, and he emphasized the relationship between vital signs and neurosurgical events. That is, any raise in intracranial pressure could lead to hypertension and bradycardia, and he employed the first neuroanesthetist. So in spite of using these clinical monitoring methods, the anesthesia was never safe during mid-90s. It was considered as a specialty with high risk because the death rate of among anesthesia was around as high as 1 in 10,000. But the alarming thing was most of them were preventable. 82% of them were due to human errors and only 14% were due to critical events. In American Broadcasting Center telecasted a program titled The Deep Sleep, where they said that the administration of anesthesia was 1,000 times more dangerous than being in an aeroplane 30,000 feet in the air. This was the severity of anesthesia fear among publics. So to combat this situation, in 1980, Chief of Anesthesia of Harvard Medical School met and started working on standardizing the monitoring methods. So they submitted their report in 1984 and they nationally standardized the monitoring methods. And these guidelines were accepted by ASA in 1986 with the motto of eternal vigilance. So let's know about the ASA guidelines in details. So it was originally approved in 1986 and they are last approved it in 2020. So standard 1 states that presence of a qualified anesthesia personnel throughout the conduct of all general anesthetics, regional anesthetics and monitored anesthesia care is mandatory. And standard 2 states that whenever the patient is undergoing anesthesia, the oxygenation, ventilation, circulation and temperature should be continuously monitored. So let's know each aspect in detail. So the objective of monitoring the oxygenation is to ensure adequate oxygen concentration in the inspired gas and the blood during all anesthesia procedures. So inspired gas concentration is analyzed using oxygen analyzer with low oxygen concentration alarm, and blood oxygenation is assessed continuously using a pulse oximeter with low threshold alarm, and patient is clinically assessed in adequate illumination and exposure for the color changes. And ventilation, to ensure the adequate ventilation of the patient, qualitative clinical signs like chest excursion, observation of the reservoir breathing bag, auscultation of breath sounds are used. And quantitative monitoring of the volume of expired gases is done through capnography, that is continued end-tidal carbon dioxide analysis in patients with endotracheal tube and supraglottic airway devices, and also when the patient is undergoing regional anesthesia with deep sedation. So disconnection alarms are mandatory whenever the patient is on mechanical ventilator. The circulation of the patient is assessed using continuous electrocardiogram monitor, and NIVP and heart rate is evaluated at every 5 minutes. The other methods to use it for the circulatory function monitors are palpation of a pulse, auscultation of the heart sounds, monitoring of a tracing of the intra-arterial blood pressure waves, and the ultrasonographic peripheral pulse monitoring, pulse plethysmography or oximetry. ASA also states that every patient should have temperature monitored when clinically significant changes in body temperature are intended, anticipated or suspected. Whenever the patient is undergoing surgery under general anesthesia which is lasting for more than 30 minutes, or any major surgery with neuroxal anesthesia, a target temperature of 26 degrees centigrade has to be monitored. Pore temperature should be monitored intraoperatively whenever possible. The sites you can assess are nasopharynx, esophagus, tympanic membrane or pulmonary artery. Axillary bladder and rectal temperature can also be used, but they are subject to artifacts. Let's know about the ISA guidelines. In 1999, ISA standardized the National Basic Monitoring Standards with an objective of safe anesthesia saves life. They say that monitoring standards cannot be universally accepted throughout the country. It has to be according to the hospital setting. They say level 1 rural setup, the highly recommended basic monitoring has to be done, and level 2, that is district hospitals, highly recommended plus recommended intermediate monitoring methods have to be used, and level 3 is referral hospitals where they require highly recommended plus recommended plus advanced monitoring methodology have to be used. Along with the ASA guidelines, ISA emphasizes on pre-anesthetic evaluation, anesthesia safety checklist, depth of anesthesia monitoring, and neuromuscular monitoring. The 5 audible alarms, what they have made it mandatory are oxygen supply failure alarm and hypoxic mixture prevention device, airway pressure limit alarms, oximetry limit alarms, blood pressure limit alarms, heart rate limit alarms. These are the monitoring methodologies which have been advised by AAGPI, that is Association of Anaesthetists of Great Britain and Ireland. Along with, they have updated in the year 2021. They insist, along with the basic monitoring methodology, they insist that patient undergoing general anesthesia with inhaled anesthetic drugs, the age-adjusted minimum alveolar concentration has to be assessed. They insist more on the procedural sedation and transfer of the patient. Whenever the patient is getting transferred, they should be assessed using the basic monitoring. And they also insist on anesthesia record with an accurate summary, and other investigations like capillary blood glucose monitoring, ketone monitoring, and blood gas analysis, hemoglobin measurement, and flexible bronchoscopy has to be available as and when required. So this was about the basic monitoring methodology standards which have been advised by different associations. So just a little glance about the advanced anesthesia monitoring. It could be respiratory system monitoring, hemodynamic monitoring, neurological monitoring, and depth of anesthesia monitoring depending upon the surgery. So we have a wide array of hemodynamic monitoring in anesthesia, along with the basic monitoring, intermediate monitoring like 12-lead electrogram, intra-arterial blood pressure, inferior vena cava assessment, central venous pressure monitoring, and serum lactate levels, passive leg raise test are the different modalities used for the monitoring of the hemodynamic status of the patient. And in advanced monitoring methodology, we have pulse contour-derived cardiac output monitoring, gastric tonometry, transpulmonary thermodilution of cardiac output, thoracic bioimpedance, thoracic bioreactance, transesophageal echocardiography is commonly used. When we want to assess the adequacy of the respiration in a patient, we go ahead with mixed venous oxygen saturation analysis, tissue oxygenation, capnography and ABG, static and dynamic respiratory mechanics, imaging and point of care. Intraoperative neurophysiological monitoring has become the need of time. So the global blood flow monitoring techniques are intravascular tracer compound determination, transcranial Doppler ultrasound, jugular bulk venous oxygen saturation, cerebral oximetry, tissue level partial pressure of oxygen monitoring. Along with blood flow, we need to monitor the nervous system function also. So we have electroencephalogram, evoked potentials including somatosensory evoked potential, motor evoked potentials, and stem auditory potentials and visual evoked potentials. And electromyography is another modality. So depth of anesthesia monitoring has entered the monitoring system few decades ago. It is to keep a balance between the anesthetic requirement and drug administration, and it is to prevent the awareness under anesthesia. Bispectral index is a modality which is used to assess the depth of anesthesia since 1992. Narcotrend index, entropy, AAP monitor, PSA 4000 monitors are the other modalities which is used to assess the depth of anesthesia. The miscellaneous monitoring methodologies are goal-directed fluid therapy monitoring, that is thermodilution technique of determining cardiac output is the gold standard for assessing the fluid monitoring fluid requirement of a patient, and indicated dilution method, esophageal Doppler cardiac output monitor, transesophageal echocardiography. Perioperative ultrasonographic evaluation has entered the monitoring system since few decades, and it has revolutionized the monitoring system. Point of care ultrasonography, that is focus, is used to evaluate the inferior vena cava, the cardiac chambers and the lung parenchyma. This was about the advanced monitoring methods which are available for the assessing perioperative monitoring. Let's know what could be the future trends in monitoring. In future trends, we might come up with more of invasive, non-invasive advanced monitoring methodologies. Telemedicine, which could be used for pre-anesthetic evaluation. Closed-loop anesthesia delivery system is a new monitoring system where it is also called as completed or closed feedback loop, and which is an automated device which is trained to a goal and govern an input that affects the goal. And monitoring system with auto correction technology are the future trends we're expecting in monitoring system. So the take-home message of this lecture could be: clinical observation and assessment by a vigilant anesthesiologist are essential for safe patient care during anesthesia. Following standard monitoring guidelines and documentation are an essential part of anesthesia care, which also prevent legal litigations. Understanding of the operation of smarter monitoring devices so that they can be used safely, accurately and appropriately. The best and the main monitor. The best and the main monitor in the operating room is you people, the anesthesiologist. These are my references. Let's practice safe anesthesia. Safe anesthesia is always safety for everybody. Thank you.